Welcome to clinical orientation for fall 2015 for Georgia Highlands College. This rotation takes place at Northside Hospital, Atlanta. My name is Malin Spinks, and I'll be your clinical faculty instructor. An important aspect of care at Northside Hospital is that Northside operates under an RN-initiated collaborative care model. The center of this model is the patient or client, as can be noted here. And the three components that I felt were most important for my attendance to the Northside faculty orientation were the acronym EQUAL, their safety measures, and their sensitivity priorities. So I've included these in this presentation. If you have any questions, don't hesitate to contact me and we can discuss your needs. We'll also go over this a little bit on the first day of clinical, but I'm hoping that this presentation handles any questions. The EQUAL acronym stands for Equal and Excellent Care. This represents excellent two-way communication between patients and providers. Northside believes that limited communication equals limited care. The Q stands for qualified. The patient and their family and you all have equal rights to an interpreter. Remember, the RN is responsible for patient care despite language barriers. Just getting by is not safest or best for the patient and is often a burden on the person being asked to interpret. Having friends or family members interpret medical information can create fear, promote anxiety, and foster dysfunctional relationships. This is extremely discouraged. The U stands for Use Teach Back to verify understanding. This is the only acceptable method of ensuring patient comprehension and increased compliance while reducing readmission rates. The A stands for Always. After the nursing note that documents the care that was given through an interpreter, always include the full name of the interpreter, their ID number, and mode of interpretation. Was it face-to-face, on the phone, or via a video format? The L stands for Language Preference. While many patients are bilingual, their comprehension of medical information may be restricted to their primary language. This means that the provider must determine their language of preference for conversation versus language of healthcare. This choice should be reevaluated throughout the course of the patient's stay. Sometimes language proficiency can change with brain injuries. As their medical needs change, the patient's ability to comprehend may convert from one language to another. Document the patient's primary language preference and remember to educate them on the fact that they have access to free interpreters 24/7. Note that there are also iPads for deaf and hearing impaired patients. While we often only consider the idea of cultural sensitivity, it's important to realize that anything, visual, tactile, or auditory, can affect our ability to be sensitive to and communicate with and provide care to our patients. The ANA specifies that nursing practice should always be conducted with compassion and respect for the inherent dignity, worth, and uniqueness of every individual. My specific goal of this slide was for you to view each of these pictures and investigate for yourself what your thoughts are when you see them, how you might react to someone with these different characteristics, and anything that you might identify in yourself that would compromise your ability to provide equal care for each of these patients. You might have communication needs. Could you speak to the elderly woman and anticipate her needs? Would you have difficulty communicating with someone from a different race, from a different culture, or with someone who has different values than you have, or that appears to? What about someone that doesn't represent what you think is how a person should take care of their body, or take care of themselves? So these are things that I'd like for you to consider. It's very important that you isolate how you think and how you feel about other people. The idea is that as nurses, we're compassionate and and sympathetic to our patients' needs because they're human, not because they are a specific race, culture, gender, religion, or any other classification.
In a hospital boardroom, somewhere in America. The case of Whitney Ross. What went wrong? In a way, I think we all wish that the result of her case had been related to her appendicitis. But it wasn't. So what went wrong? And what can we do to fix it? Whitney was a sophomore in college, an excellent student with dreams and goals. She came to be in post-op after having an appendectomy.
Still doing a little bit of everything.
Yeah, yeah.
But this IV line still really hurts.
Well, like I said, I can try moving it to the other arm.
Yeah, whatever you could do.
Sure. Is that a rash?
Oh, my cat scratched me a few days ago. I told them when they took my history.
Okay. It shouldn't be a problem if the IV is down by the wrist.
Thanks. Sorry to be such a bother.
I'll be back in just a minute.
Okay.
The probable source of the infection was down the hall. Tom wasn't even supposed to still be there, but he contracted a MRSA infection at his surgical site. His daughter, Kelly, unfortunately didn't understand that even though she was just a visitor, she was also a part of the healthcare team.
Hey, my dad could use an extra pillow for his back.
Okay, I'll bring you one in just a second.
Kelly had been educated by a nurse about the barrier precautions and the dangers of healthcare-associated infections, but she didn't quite grasp how just one lapse can cause infection to spread. Dina? She was a good nurse, but was burned out with stresses at work and home.
I know you're always busy with all the paperwork you're doing, but if you could get to us soon.
She wasn't going the extra mile to ensure the safety of patients.
I just need another minute or two, and then I will bring you a pillow, yes.
Thanks.
She recognized Kelly wasn't using the gloves correctly, but didn't use the opportunity to educate, and didn't take personal responsibility for cleaning a potentially contaminated surface.
Whitney's IV still hurts. I'm going to try moving it to the other arm. Can you cover Mr. Daniels for a few minutes?
Yeah, I wasn't going to finish this anyway. Thanks.
She was using gloves, so she didn't also feel the need to wash her hands. Nathan's staff did everything right when he was around. But there was no sense of ownership, no real change. There wasn't 100% commitment.
Oh, it's so much better. Thank you.
Let me know if there's anything else you need.
Is it cold in here?
I don't think so, but I can get you another blanket.
The nurse made a note in a chart, but didn't alert anyone until after shift change.
Temperature is 101, blood pressure 145 over 97, nothing moving in her GI tract, hypoactive bowel sounds. Looks like it's ileus.
Guess you stand another day. Let's see what Dr. Kennedy says. Thanks.
Manuel, in his third year of med school, he longed to make a difference.
A temp of 101 is fairly typical for appendicitis. Let's monitor the postoperative ileus for 24 hours.
But the patient got worse.
She's been acting a little confused, but her temperature went back down. What concerns me is her arm. Look.
Manuel had been watching the case all day. He suspected the patient's condition was getting much worse.
I saw that. But it's here in her history. Her cat scratched her arm and she got a rash. Did you read her history, Manuel? Let's stick with...
Dr. Kennedy directed the team to continue the antibiotics already prescribed for her appendectomy and closely monitor her condition.
Monitor for peritonitis. I'm on call this weekend. Alert me if she doesn't respond.
But Manuel's rotation in post-op was almost over and he didn't want to stick his neck out. Manuel accepted the attending's course of action without objection. When it came time to make a difference, he didn't speak up, even though the problem was staring him in the face. 48 hours later, the nursing assistant took Whitney's vitals at shift change, including a temperature of 97 and blood pressure of 90 over 60. But Manuel just recorded it and never related to the nurse or bothered Dr. Kennedy because it was the weekend. It was a chain of events that should not have happened. By the time she reached the ICU, she was suffering from organ failure as a result of sepsis. And then...
Hey, Dr. Green. Everyone. The ICU just called me. Whitney from 204, she had a MRSA infection in her bloodstream. She passed away.
Go back in time and make better decisions so that this is you.
Doctor said I healed up fast.
And not this. Take a walk in their shoes. If you're smart, we can improve quality of care and save patient lives.
The lift equipment available at Northside consists of all of these pieces of equipment that you see here. Each one is named, so if you don't know what it is, please look it up online, get a picture in your mind, understand what it can do. I've listed here kind of a basic outline of what each is capable of and what it's appropriate for, where it's located, and whether or not you have to sign it out. The only one that I specifically want to mention here, well, actually there are a couple. The pink slip, you never ever leave a patient alone on this. They will slide off the bed. The ergo nurses, I think they said there are only 1 or 2 in the whole entire hospital. So, if you have a patient that's maybe somebody that's post-op that you can't turn yourself, or 2 people can't turn, then that patient could potentially be on this. But we're thinking more like an ICU patient. The other one that I wanted to mention was the Galvo. It is for getting people in and out of cars and for gate training events. You can see all that here, but you should not use this. I would prefer that you not even investigate this. If you are discharging someone, the nurse will probably have to go with you or participate in that process, so she would be the one to decide whether she wanted to use that or not. If you have any questions, like I said, please just research Google and YouTube. That's what I do when I don't know something. So feel free to start that process if you're not used to it. And if you have any trouble, you can contact me. One method that almost all hospitals have is clinical quality with armbands. What you'll notice at Northside is that they do not have an allergy armband that comes up when you enter a patient's EHR system file, and so they will not have the typical red allergy band that you may be used to seeing. The ones that are most common are listed here. The most important thing for me is that you do not remove nursing home bands, the armbands from nursing homes, and I'm not actually sure what those will look like. Different places will have different options, but one of the things they recommended was that you tape over them and secure them to the patient so that they're not distracting. I don't recommend that. Even if your nurse recommends that you do, or she does it herself, that's fine. You can leave that alone. But because I don't know exactly what those bands constitute, whether they're plastic, whether they're paper, I would just prefer that you learn to not be distracted by extra armbands, understand what they mean and what they stand for, and if you identify a patient that does not have one that needs one, then please pursue that. You can contact me and we'll do that together. But anyway, so on here you've got your yellow fall risk. You're more than capable to read this yourself, but just realize that the orange band is something that you will document every shift, every first initial assessment. You should put in your notes whether your patient is a DNR or not. Okay? So I'm sure that you guys will have many more questions. This was just the basic information that I felt necessary for us to get out of the way. Like I said, if you have any more questions, you can either contact me or we can talk about it the first day of clinical. We will have an orientation to the unit that we're going to be on. We will be dispatching 2 students each clinical shift to orient with. One will go with the IV team, and I believe the other will go to some other department. I can't remember. GI lab, I think, is what they opted for. But those are the kind of specifics I'm not going to know for a couple of more days. I do have your names in the clinical groups that you're in. I'll be emailing this PowerPoint to people individually. This is not to be visualized by people outside of my clinical groups. This is not applicable, and so that would be unnecessary. My number is here with its limitations and parameters. I ask that you respect my request for times and concerns, and anything outside of emergencies or things that are listed here, absolutely email me or just see me in the hall. My office is 180D. You're more than welcome to stop by. I'm always on campus on Monday. Until clinical starts, I'll be around. So, and if I need to make an appointment and come in, I can. Like I said, at orientation, I do live in Stone Mountain, so it's about a 2-hour drive for me. I'm more than willing to make that drive to meet with you. But I just would ask that you consider whether it's necessary that we do face-to-face or if it's something we can do via email or on the phone. All right, I look forward to having a great semester with you and helping you with your nursing. And let's just have a good time and keep patients safe and ourselves safe as well.